Hi, everybody, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator for MS Focus, and today I'm joined by not one, not two, but by three doctors. We have Dr. Sargent, Dr. Shine, and Dr. Chaifetz, who will be discussing MS care in a team approach, which is a team approach. After their presentation, well, actually, normally I'd say we're going to open it up for questions and comments, but this time we're going to actually allow you to ask your questions in the middle of the webinar. So if you have those, you can either go ahead and put it in the chat, or you can raise your hand in the app and we can call on you, and you can unmute yourself and we'll unmute you. I am going to go ahead and let each one of them introduce themselves. We can start with Dr. Ashley Sargent. And why don't we start with you? You can tell who you are.
I'm Dr. Ashley Sargent. Currently, I am the ambulatory care clinical pharmacist in our neurology clinic outpatient at UF Health Jacksonville. I completed my undergrad degree originally back where I'm from in Philadelphia at St. Joseph's University, where I received my degree in chemistry. Then went on to pharmacy school, also in Philadelphia at Thomas Jefferson University for 4 years, and then completed my postgraduate year one at Anne Arundel Medical Center, which was in Annapolis, Maryland, and then finally made my way down to Florida for my postgraduate year two training, which I did complete here as well at UF Health Jacksonville in our ambulatory care PGY2.
Thank you. How about Dr. Shine?
Hello, everyone. My name is Dr. Dionna Shine. I also am a UF Health pharmacist here in Jacksonville. I'm a first-year pharmacy resident, and I actually did my postgraduate training here, or my graduate training here at the University of Florida as well for pharmacy school at the Jacksonville campus. I also attended the University of Florida for undergrad as well, where I pursued my pre-pharmacy degree. So excited to be here.
Thank you. How about Dr. Adam Chaifetz?
And I'm Dr. Chaifetz. I am the program coordinator for the Comprehensive Multiple Sclerosis Center here at the UF Health Jacksonville in the Department of Neurology. My background is in chiropractic medicine. I've been in clinical practice for 37 years. My undergraduate degree is from the University of Massachusetts, Boston, in community studies. I received my Doctor of Chiropractic degree from Life University, and I have postgraduate training in neurology from Northwestern University in Minnesota. I've had the pleasure and opportunity to work with the Multiple Sclerosis Foundation for many years, and today I would like to share with everybody how we as a comprehensive MS center do things in a team approach. So if we're ready to get started, then we'll just go right ahead and get going.
We are. Thank you. We're thrilled, by the way, to have all three of you. This is super exciting.
Yeah, just as an aside, it should give you a little bit of understanding that not only does your neurologist, your medical physician, have a doctorate degree, but many of the folks who work behind the doctors, I call them the doctors behind the doctors. Many of us are eminently trained, have gone to, really eminent institutions. And it's that camaraderie among the different disciplines that really helps us excel as a program. So the first thing I think that's important to understand is that we're here presenting without any bias. And that's the reason that we feel that we are a comprehensive center, is that we don't have any ill feelings about any treatments or any strategies for the management of multiple sclerosis. We do use evidence-based guidelines. So we don't just do things because people think it's okay to do it or because it's a suggestion. So we also do not have any financial conflicts. So we're not being paid by any pharmaceutical companies or anybody to speak or do this lecture today, okay? So it's important to understand that in the realm of multiple sclerosis care, there are some very, very eminent, prominent neurologists out there that have training that may not have that comprehensive MS center designation, but they're fully qualified to treat multiple sclerosis. And based upon many factors, where you live, accessibility to healthcare, type of insurance, there are a lot of factors that go into the ability of a person to actually see a person so specially trained in multiple sclerosis. So we're lucky because in our MS center makeup, in our comprehensive center, we have neurologists, neuropsychologists, physical therapists, several clinical pharmacists, and a dedicated social worker. Now, what I didn't put in there was a dedicated MS nurse because, quite frankly, they're very hard to come across. And any practice that has an MS certified ARNP, that is a bonus to any program because they're so few and far between.
Excuse
So
me, Dr. Chaifetz, I don't mean to interrupt you, but can you put your slides up? Because nobody got to see that one, and that's a really good slide to begin with.
you can't see the slides?
No,
I think when she started.
All right, let me just see what went wrong here.
Go back up like there in the green share button and then screen one and then.
All right, let me get this together. How's that?
there you go. That's what I wanted everybody to see. Thank you.
Okay, so yeah, that makes it a little bit easier to understand, doesn't it? So as I said, your average neurologist may have his staff to work with, and then they're going to have a series of people that they work with for ancillary care, like physical therapists, psychologists. But most MS centers have a group assembled that are able to handle a condition like MS and have specialty in this discipline. So it's important that each of them have certain certifications. So if you look at our setup, I'm an MS certified specialist. Our physical therapist is an MS certified specialist. And also all of our pharmacists by now have had enough experience in dealing with MS patients since pretty much working with our program that we're able to hone in and look at specific things dealing with, for instance, pharmacy that impacts patients and their ability to get their medications. Now, another thing about being a comprehensive center is that we offer complete therapy options. So those therapy options, for those of you that are new to multiple sclerosis, multiple sclerosis care has changed quite a bit over the past 15 years. When I started, the drugs that were used were all injectable drugs. You had only 4 or 5 to choose from. And if you failed on an interferon drug, the only alternative was going to be glutamer acetate. So when we look at the complete line of therapy options as an MS center, we consider almost all of the option drugs that are available. When you look at what an insurance company's perspective is, they have a completely different perspective on what they want to cover for a patient. And so there's this concept in care that's called platform drugs. Would any of you guys like to talk about what a platform drug is for like MS, for instance? Okay. Well, so our pharmacists are also recent graduates, so they weren't around back in the days when only the injectable drugs were around. So if a patient is diagnosed now, brand new diagnosis, and their neurologist is going to try to get them on a therapy, the insurance companies are going to push for the patient to have the older, less expensive drugs. And those drugs are known as platform drugs if you're looking at it from an insurance perspective. Okay, now from our perspective, any drug that's FDA approved for relapsing, remitting, or secondary progressive multiple sclerosis, any drug that's approved for that really can be prescribed for a patient. But the obstacle is getting insurance to cover it. And now that there are 20 drugs out and there are several drugs that are generic, the whole landscape for procuring medications for patients has become very, very difficult and very taxing and confusing. So when we look at the original platform drugs, and we may have a lot of people that are still on these drugs, and if you are on these drugs, they still are very effective and very safe choices for patients that have relapsing MS. And these are going to be Avonex, which is an interferon, beta-seron, which is an interferon, Rebif and Plegridy, which is an interferon, and then you have your Copaxone and glatiramer acetate. These drugs, being what are called the platform drugs, are obviously the drugs that have the least effectiveness. And these drugs now are rarely used as a first choice for a newly diagnosed patient. And the reason is there are other options such as oral drugs or infusion therapy that are more effective and more convenient for the patient to take. So if you're a new patient and you've been diagnosed, your insurance company wants you to try and fail certain drugs before you can get to the next level of treatment effectiveness. And when you think about that, that's not a real good thing with multiple sclerosis. Because if you have to try and fail a drug, that means you literally have to go through a relapse and possibly suffer a permanent condition that may never improve just to get a better drug. So those in the MS world that actually prescribe these drugs because they know what they're doing, they will pick drugs that are of higher efficacy than what the insurance company likes to approve, because we have experience in knowing that certain types of multiple sclerosis are actually aggressive and require a much more effective option. So if we look at the second line of therapeutic options, these are your oral drugs. And coincidentally, every one of these drugs, Tecfidera, Gilenya, and Aubagio, every one of these drugs now are generic. So if you have been on any one of these brand name drugs for many years, you probably by now have learned that the programs for support, whether that's copay assistance or free medication, has probably evaporated because of the presence of these generic drugs. And then the CD20 depleting therapies, these are the highest level therapies. What these represent would be infusion drugs and high-level injectable drugs like Kesimpta, Briumvi, and Ocrevus. One of the things that we do, and Dr. Sargent participates with our group, every other Thursday, we have a meeting of all of the providers in the MS program, which includes our MS secretary, who is Mae Brown, who is an exceptional secretary who knows her stuff, our pharmacist, Dr. Ashley Sargent, our physical therapist, Dr. Brittany McHugh, our social services director, our infusion pharmacist, Dr. Nisha Taliani, Dr. Katsapanis, our MS provider, Dr. Silliman, our MS provider. So what we do is we conference on cases and we talk about strategies on how we're going to manage patients with the type of insurance and the aggressiveness of their condition. So one of the things that we do is we ask the pharmacists to consult with patients once they've chosen a drug, and the drug that they go on, the pharmacists are going to be able to counsel the patient on whether that drug has any risks given their health conditions, whether that drug is going to interact with any of their current medications, and lastly, whether the drug is going to be obtainable and affordable. So that's the way that we work in seeing a patient get to a point to where if they're brand new and they're being diagnosed, we manage their case in the beginning, and then as the ongoing management happens, we bring up cases to discuss every other week, just so that we have a strategy to know when a patient's doing great versus when a patient needs additional services.
Dr.
So we have
Chaifetz,
this,
I'm
yeah.
sorry. I'd like to interrupt for just a second because we do have a person asking a question. Do you want me just to go ahead and ask you as they come in, or do you want me to save them for a little bit?
No, we can field a couple of questions. Go ahead.
Debbie wants to know if you know when Ocrevus is going to become generic, and when does the patent expire?
Well, the thing about it is we don't know. You probably, I would say that many of the infusion drugs, you're going to find biosimilars coming out in the near future. I mean, that's a given because of the costs. But the problem when these drugs do go generic is depending on the type of copay support program, many times those programs go away when these drugs reach a generic status. So that's the downside to drugs in the MS world becoming generic. Now, what's the plus side? The plus side is some of these drugs are very affordable on Good RX or Mark Cuban's Cost Plus. So if you're on, for instance, generic Aubagio or generic Tecfidera, these are drugs that are very affordable, even if a patient doesn't have insurance. But infusion drugs, these are the highest level drugs, and we're seeing just a trend in biologics where there are biosimilars that are coming out. Are you all seeing that for just across the board in pharmacy, period?
Yeah, so some of our other specialty clinics here that other pharmacists work in, like our gastroenterology clinic and whatnot, a lot of biosimilars recently came out for like Humira and Remicade. So that's kind of more affordable for the patients. But once it started coming, there's a ton of biosimilars that keep coming out for those same medications.
Yeah, and like for this patient who's asking, as a matter of fact, when I started, we used to use Rituxan for patients that had aggressive MS, and the complement to Rituxan nowadays is Ocrevus. And what's funny is we've actually had insurance companies 15 years later tell us that they would approve Rituxan, but not Ocrevus, and it's still not FDA approved for multiple sclerosis. So when you look at the insurance perspective of how to treat a disease, it's completely different than the provider perspective.
Thank you.
Because we can only use FDA-approved drugs for insurances to cover them because of the cost being so extensive. Right, ladies? Yeah. All right.
Thank you.
Another question, or we keep
Nope,
going?
as they come in, I'll interrupt you again. I'm sorry.
Okay, and so another thing that we do at our case conference management is when resident doctors have MS cases in their resident clinic, we're training 16 residents in neurology also. And some of these doctors are just learning the art of neurology as well as the management of neurologic conditions. So sometimes they need guidance from specialists like our attendings to learn what the best course of treatment is for a patient that has a certain presentation. And we see a lot of really, really aggressive cases here that need management like ASAP. So we have to try to educate our residents to do their best, not only in treating the patient in the hospital, which is where they see them a lot of times, but to follow through with that treatment in the outpatient setting. And so believe it or not, if it's confusing for a patient to understand that there are 20 drugs out there, trust me, these doctors, it's confusing to them too. All right. So one of the things I think that's important to understand about the way that a neurologist prescribes has everything to do with their specialty experience in multiple sclerosis and demyelinating conditions. Okay, because a neurologist can go through their training and learn about MS, but that doesn't make them a specialist. So a lot of times we end up managing or co-managing cases from general neurologists who do not feel comfortable in managing aggressive cases with drugs that are considered to be like chemotherapy drugs. All right. And so our specialists are dedicated to MS. We have experience in research, and hopefully we're going to be doing more trials when we add our 2 new providers next year. And it's important to really understand the intricacies of MS. One of the valuable things about the Multiple Sclerosis Foundation, and one of the reasons I love listening to the lectures myself, is when you tap into people like Dr. Thrower, for instance. There's a doctor who knows multiple sclerosis in and out. And that is the kind of doctor that I work with, Dr. Silliman. And it's really refreshing to know that you can go to a person that educated who knows this condition inside and out. And the thing I also love about Dr. Thrower is his complete honesty in explaining anything that a patient asks. And he truly represents what a comprehensive approach is to managing MS, because we realize that medicines are part of the picture, but there's also ancillary things that can help patients get through managing this condition. And I think it's important as a comprehensive MS center that we offer absolutely everything that's available to the patient. And that's one of the things that maybe a general neurologist who sees MS, not as much as a specialty clinic, that they're not going to get that benefit of that experience. And the thing is too, is we find that there are doctors out there that are biased against prescribing certain treatments. All right, so am I actually going backwards on this? Okay. What slide do you all see? Additional first-line therapy?
Yeah.
Okay,
Yeah.
so I'm going to talk some more about what we consider to be a first-line therapy. Any and all of these therapies listed here, we would start a patient on first-line therapy, meaning that if they were just diagnosed, we could or would choose one of these medicines. So we'll go down the list. The oral medicines are Gilenya, Zeposia, and Mesa. These drugs here are probably some of the most problematic to start a patient on because they require a lot of blood work and pre-screening exams to get on the drug. Another reason that I am not a huge fan of this class of drug is that if a patient goes on this medicine and for some reason they fail on this drug, it can lower the lymphocyte count so low that the patient may have to wait several months to start a new therapy. And patients who are on a high-level therapy like fingolimod, they can't really afford to be off of a high-level therapy for several months. So that's one of the downsides that I've observed as a person who manages patients behind the scenes, changing from one drug to another. Would you ladies agree?
Yeah, I agree.
And the thing about it too is that everybody remembers the first oral drug, which was Gilenya. And the nightmare associated with this drug is that you had to go through a 6-hour observation where you sat in a doctor's office for 6 hours, had your blood pressure, pulse, heart rate taken every hour. And if it dipped too low, you had to admit a patient to the hospital. So it was a very labor-intensive drug. And so if patients were on these drugs and they went generic, unfortunately, the programs for assistance stopped, and there's a lot of shuffling that goes on from one of these drugs to the next if a patient loses their assistance. But the thing is we have other choices though. Aubagio or teriflunomide, that drug is also available on a generic basis. It's a very inexpensive drug. Tecfidera, dimethyl fumarate, is also a generic drug that's very affordable. But you know what we're seeing also, and I think, Ashley, you know this, that we're even starting to see GoodRx and Mark Cuban's running out of supply because of how many patients are using this avenue. Okay, and just to put a little perspective on it, one of these drugs, I won't mention the name, one of these drugs is $12,000 a month if you buy the brand. It's $12 a month if you buy it on Mark Cuban's. So it's only 1,000 times more. So kind of gives you an idea of the margin there of markup. But anyway, most insurances have what's called a formulary, and they engage in a process called step therapy, which means that if you're newly diagnosed and your neurologist wants you to have an infusion therapy right off the bat, what they're most likely going to say is, we will not approve this until the person tries and fails several formulary agents. And what it is it's a back and forth between the insurance company and the office to where we have to appeal it. and try to convince them that the patient requires a higher level drug than what they want to pay for. And many times that process is, well, how would you guys explain it?
It's very tedious. It takes a long time. It a lot of times requires us to have the denial, send some type of paperwork to the patient to sign off on. We have to write up a medical necessity letter, get the provider to sign that, get an addendum in the notes, like the clinical notes that the providers write, to send that over. So it's a very tedious process that takes away the time the patient could be on medication as well.
Right, and if any of you have followed politics at all, the Congress recently had a hearing about pharmacy benefit managers and how these pharmacy benefit managers are actually adding to the cost of medications because they're a step in the process that's not necessary. All right, it's like let's say Wendy's decided that they're not going to sell you hamburgers anymore, that you have to go and buy it through Grubhub now and spend $14 to have a $5 hamburger delivered to you. That's kind of the setup that these pharmacies have. And then if we look at the high level drugs, these are the infusion drugs. This is Tysabri, Ocrevus, and Briumvi. So when we put patients on these drugs, a lot of times they're going to have a more aggressive course of MS, and they're going to require a higher level therapy. And even though these drugs are higher level therapy, they're much more expensive. So these insurance companies absolutely have a reason to have a stake in understanding why a patient is being prescribed a certain therapy. All right. Now, for those of you that are new to MS, when you're prescribed a therapy, usually it's an indefinite thing. Your provider doesn't know how long you're going to be on this therapy, because the goal of therapy is to control your condition to where you don't have relapses, you don't have clinical progression, and you don't have any changes in your physical status. There are two therapies that are very unique to the MS treatment world. One is an infusion, and the other one is an oral therapy. In previous lectures, I've touched upon these drugs, and when I say that these are unique, each one of these drugs only has a treatment duration time of 2 years. So with Lemtrada is an infusion where the patient does 5 straight days in an infusion center and then waits an entire year, and then the next year they do 3 straight days of an infusion. We've had probably 10 or 12 patients that have had this infusion done, and we've had several patients that after this therapy have never had to be treated again with another MS therapy. Their condition is stable, their MRIs are stable, they've had no progression clinically or radiographically. The second drug that is very similar is called Mavenclad, and this is an oral drug that the patient takes again for 2 years. This is an oral therapy that's taken for 1 week. A month later, you repeat the therapy, and then 1 year later, you repeat the oral regimen that you were prescribed. It's a weight-dependent therapy. So you could take as little as 5 pills for the week or as many as 10 pills for the week. And the goal of these two therapies, these two treatments work unlike other therapies, and they literally reboot or reconstitute the immune system and cause it to hopefully function normally. So we talked about interferons versus glatiramer acetate. Each one of these has good efficacy, but honestly, nowadays, this is not really a huge discussion because patients that fail injectables usually will go to a higher level oral or infusible drug. So let's talk a little bit about the type of MS. I was listening in on a lecture, I believe it was the African American experience with MS that the MS Foundation did. And I heard some of the patients, some of the participants talking about some of the types of MS that they had, and they didn't really sound like they had a huge understanding. So I was just going to review that a majority of people have relapsing MS. About 80% are going to have a form of MS that is a relapsing form that shows defined periods of aggravation. Now, this is off drug because when we put a patient on medication, we don't want them to have exacerbations. Usually, a patient with relapsing MS is responsive to steroids. And the other thing is that as their condition progresses, you see lesion activity on MRI with enhancement, which means that this is continually inflammatory lesion activity that happens within the past 90 days. The second type of MS is progressive MS, and progressive MS will usually follow a period of relapsing MS after about 15 years. But you can also have primary progressive MS, which is a different form of MS. It does not have periods of exacerbation. The patient just has a slow, steady decline over a period of time without any active periods of relapses. So when we talk about progressive, it really is going to depend on what your initial diagnosis is, because anybody who's been on more than one MS therapy has had a relapsing form of MS. So how do we know if a person's progressive? Well, it's going to depend on the experience level of the neurologist who diagnoses you, right? And some patients, unfortunately, after they've had relapsing remitting for 15 or 20 years, their condition becomes very quiet. And so if that happens, some patients might be labeled in a secondary progressive mode to where their neurologist may actually take them off of therapy, okay? And there are cases where neurologists are removing patients from therapy if they feel like their condition is stable enough. We honestly do not remove patients from therapy if the therapy is keeping them stable, relapse-free, without progression. And then your primary progressive form is a very small percentage of the MS population. And when it comes to treatment, there's only one option. There's only one FDA-approved treatment for primary progressive MS, and that is ocrelizumab or Ocrevus. So if you're on a different drug than Ocrevus and you've been told that you have primary progressive MS, you may want to think about a second opinion. Secondary progressive has an active and a non-active phase. So the drugs that are used to treat relapsing MS are going to be exactly the same drugs that we would use to treat a secondary progressive patient. Would you guys agree? Yeah. All right. All right. So how does MS start? Let's look at how this crazy condition starts. If anybody's ever been to Disney World here in Orlando and been to Space Mountain, this is not it. Okay, even though it kind of looks like a space frontier kind of setup, what you're actually looking at is the way that our immune system interacts in a negative way with our nervous system. Our immune system is composed of B cells and T cells. So what you see here are circulating immune cells that actually go through the blood-brain barrier here. And when the T cell penetrates through the blood-brain barrier, it causes cytokines to be activated, which in turn causes an autoimmune response against the nervous system. So in short, this is how these immune cells that normally would not attack the nervous system get through the blood-brain barrier and actually start attacking the neurons of the central nervous system. So this right here is a neuron, and these neurons make up the brain and spinal cord. So the way that multiple sclerosis drugs work is they work in two different ways. They work by either blocking the way that these T cells are migrating into the central nervous system, or they completely reduce the number of circulating T cells, which decreases their ability to attack the nervous system. So this is where we get into defining whether a drug is an immunomodulator or an immunosuppressant. Why is that important? It's important to know because immunosuppressant drugs will depress your immune cell count, which can expose a patient to things like infections. And so one of the things Dr. Sargent can tell us here, when you interview a patient who's going to be starting Ocrevus or Kesimpta, what are the things that you consult with the patient about that's important before starting this drug?
Yeah, so with those having, a higher risk of that immunosuppression, like Adam was saying, we really want to make sure that they have a good set of baseline labs. So we're looking at things like immunoglobulins that we want to be normal so that, you're not increasing that risk of infection. We're going to check a hepatitis panel, specifically that hepatitis B, to make sure, we're not at risk of that infection. And we're really going to be looking at white blood cell counts, like our lymphocytes here, our B cells, our T cells, to make sure that those numbers are high. We usually here like them to be higher than around 800 to be in that safe range to go ahead and start the therapy. If we do end up having all those baseline labs, they look good, we kind of just go through different counseling points with patients. So really focusing on, what the drug dosing is going to be, how that infusion experience or injection experience is going to be, really helping out with side effects that may pop up. Not that, they always happen, but just making patients aware that potential things could happen. And if they do, ways to kind of lower those risks from happening. So a lot of times with these infusions, you can pre-medicate with different things to help reduce those infusion-related reactions, or injections too, like Kesimpta. Really, you can take, your ibuprofen, your Tylenol, antihistamines, things along those lines to help reduce those injection site reactions that may occur. But just really making sure the patient's fully comfortable and they can ask any questions they have to me about the medicine before moving forward, so that they feel like they can inject it on their own or take it on their own at home if they're doing so. And just knowing that we're closely monitoring those labs to follow up so that they maintain in those normal limits for counseling points as well. Another big one too is vaccines as well. So making sure if vaccines are needed, we're getting those timed appropriately. That's the safest for the patient to start treatment. as well. And then honestly, if pregnancy, you know, for those women of childbearing age, really focusing in on that to make the patient feel most comfortable. And also the biggest thing is making sure they're involved in the decision making as well.
So yeah, and another thing we try to do too is, let's say we have a patient that needs to be on a CD20 drug, which would either be Kesimpta, Briumvi, Ocrevus, but let's say that they live in a remote area and they're compromised for their mobility. Well, Dr. Sargent might help Dr. Silliman and Dr. Katz-Vanis realize that maybe an injectable form of a CD20 might be a better option for a patient given their living circumstances. So this kind of gives you a little window into how we use our specialists here. And keep in mind that, you know, the average neurologist is probably not going to have access to a clinical pharmacist within their department. So, so anytime you have the opportunity to interact with a clinical pharmacist, you know, they are a great resource, and we are really, really gifted that we have the ability to not only utilize clinical pharmacy, but also train clinical pharmacists too. So we're very proud of our setup. Now,
Excuse
one
me.
of the things I wanted to do that I haven't seen a lot of people do in MS presentations is go over what these lesions look like on MRI. So when we look at MRIs, this image here is what we call a sagittal section. This is a brain MRI, and probably many people didn't realize that the brain itself is not a solid structure. It's a hollow structure, and in the middle of the brain, you have a ventricle system that circulates fluids. So one of the hallmark key signs that we see on an MRI for patients with MS are these lesions, which are called periventricular lesions, which means surrounding the ventricle. If any of you patients have read your MRI reports, you have seen this verbiage. The next one here, these are what are called juxtacortical lesions, and these are lesions that are seated within the deep white matter of the cerebral cortex. Now, if we only had like one of these lesions, like this little one here, or for instance, this big round one here at the posterior, we may not necessarily know that this is MS, but one of the things that gives us a very strong hint that this is multiple sclerosis is seeing the lesion formation right in the middle of the brain, right where the ventricles are. So remember the last view, periventricle. So these MS lesions like to hang around the ventricle. So how do we know that? Well, we know that because this person, Dawson, he observed it as a radiologist or a neurologist or just a crazy person who likes to look at images. I don't know. And so what we have here are projections that actually come out of the ventricle in the middle of the brain, which are called Dawson's fingers. So when you see these hallmark lesions along with the patient history, along with blood work, sometimes, if not, you know, depending on the circumstances, we also do a lumbar puncture. So these are all the things, all the tools that we use to determine the aggressiveness of the person's multiple sclerosis. Now, what you're looking at here is cortical atrophy basically means brain shrinkage. So what you're looking at here is loss of brain volume. So when you see a patient that has cortical atrophy, the butterfly, as I call it, in the middle of the image looks enlarged, okay? And the reason is because you've lost neurons that would normally make up that space. So when you see cortical atrophy in an older person, like if you were to do an MRI on my brain, you would probably see cortical atrophy because I'm 64 years old. But if you did an MRI on a 20-year-old and saw cortical atrophy, that would be not a positive sign that you would want to see for a young person. So MRI tells us a lot about not only the condition, but possibly how long the condition has been going on. And these are spinal cord lesions. And the reason why you don't ever want to undertreat a person with MS that has spinal cord lesions is because you can have some pretty dramatically horrible things happen. If you look here where the arrow is, this person has a lesion at about the level of C3. This lesion literally occupies the entire space of the cervical cord here, all right? And that is in the top left image. If you look at this image here, the top right image, the arrows here point to two different lesions, one at T3 and one at T4. These are also rather large lesions, but there's really nothing that compares to what's at the bottom of this page. When I saw this example, my jaw hit the ground. What you're looking at is a progression of A, top left, B, top right, C, bottom. This person's spinal cord is inflamed. It went from this, oh geez, how do I get back?
The left arrow, click on your keyboard.
Okay, sorry about that. You got my technical wizards here. So this progressed from this to this, okay? And to those who don't know how to read MRIs, it just looks like somebody colored in with a white colored pencil. But at this moment here, when this person's cord literally is inflamed, they became a paraplegic. And this right here is the recovery MRI. And if you read the fine print here, the person only made a partial recovery. So what that means and what that is a lesson of, it's a lesson that MS is a condition that should not be undertreated. It should not, the neurologist or the treating provider should not give in to an insurance company if they feel that a higher level drug is indicated for this person's condition. And so most patients who will fail injectable and oral therapies are going to have to go to a higher level therapy. And these therapies are more risky. And the more risk that comes with the therapy, the more patients are afraid to take them. And so what we find in the MS world is that MS patients have to make decisions that are very dramatic, and they have to depend upon the professionals that they go to for the guidance so that they can be guided towards the best therapy for their condition. And so that's why we highly recommend this team approach of management, because it gives the patient an opportunity to utilize not one, but many individuals who have expertise in treating a condition that can be very debilitating.
Thank you. I have a couple things in our, one in our chat, one in our Q&A. Can I say those?
Yeah, go right ahead.
Okay. So Troy was just diagnosed, I believe, just recently. And he said, I've not felt my hand since October. I had an MRI in May showing over 20 lesions in my brain and multiple on my C-spine. I just saw a neurologist and he said I have progressive form of MS and have had relapse remitting MS for years. He wants me to do a T-spine MRI in a couple weeks, then meet with him again in September. Do you initially recommend any treatment options? I have been dieting and the doctor continues to ask me about oral medicine and Kesimpta as a secondary for self-injection. I asked for IV infusions, but it sounds like the doctor is seeking the lesser cost drug, which is his guess based on what you're suggesting, doctor.
Okay, we obviously can't give medical advice. This is what I would say. If he said that you had relapsing remitting initially, then you most likely have a secondary progressive form of MS. So the way you would treat it would be exactly like you were treating relapsing MS. Now, 20 lesions to me, we have patients that have 20 lesions that have had MS for many years too. So I think that as a patient, I would ask the doctor what his top 3 recommendations would be. And then I might see about a second opinion if there is an opportunity for you to see somebody who's more in line, that has more expertise with MS. Unfortunately, anybody who presents on a format like this, we obviously can't give you direct medical advice, but it sounds like he is working in the right direction. And depending on your type of insurance, the thing you can do is check your insurance formulary for what drugs are available for you. And if you and do your research and see if you like any or all of these drugs. And if you have the opportunity to speak to a pharmacist, query a pharmacist about the risk benefits. Because believe it or not, our providers go to the Pharm divas here for advice when it comes to drugs, believe it or not. They are the experts when it comes to drugs. So anytime you can utilize their expertise, we appreciate it. And so that's what I would recommend. But it sounds to me like your doctor's on the right path. Okay, if he told you there was nothing that could be done, I would be very concerned. But it sounds to me like he's on the right path. And if you have questions about the efficacy of it, do your research and challenge him. Say, look, I've done my research. I feel like maybe this drug might be a little bit more efficacious given the number of lesions I have, and I'm concerned about it. And if you have spinal cord lesions, I would absolutely stress the point of a higher level therapy.
Thank you, Dr. Chaifetz. That was a great answer.
Yeah.
We also have somebody saying, is there a way to estimate how long a patient has had MS based on an MRI, not just since the onset of symptoms?
So we're not forensic pathologists. We can't timestamp somebody, but we do know on certain MR, like when we look at a T1 MRI and we see black holes, that usually indicates more of a long-standing course of MS. When we see patients that have cerebral atrophy, that indicates a longer standing bout with MS. But in terms of like, we have no idea when we're looking at multiple lesions, which lesions occurred first. The only way we know that is if when we do a contrast MRI, if something lights up on contrast. If something lights up on contrast, then we know that that lesion has occurred within the past 90 days. Other than that, we don't have a timestamp for lesions.
Dr. Chaifetz, you know your slides are good when Debbie wants you to, not me, Debbie, but Debbie who's visiting us today. She wants you to show these slides to the insurance companies. She said that would be good. And thanks for including them, she said. They're very informative.
Yeah, pardon me for cussing, but they suck. They really do. Um,
Oh, funny.
so in conclusion here, you've seen probably one of the best examples of a bunch of experienced people who really like each other, work together to try to accomplish what's best for the patient. And it's unfortunate that not every MS provider can have a complete setup of having a team like we do. And one of the things that I think it's important to understand is that the patient absolutely needs to be a participant in this process. And if a person who's a patient feels like they don't have a say-so in their care, that's not a real positive way to go forward. So you do have to establish a rapport with your provider to where you trust what they have to say. And also, the provider cannot do it on their own, because once the provider picks the drug, that's when the hard work occurs, when the staff behind the scenes goes to work trying to get what is important for the patient approved. So our MS secretary, May Brown, she battles every day with insurance companies, with specialty pharmacies, our pharmacist, Dr. Sargent, Dr. Shine. They battle every day with specialty pharmacies that want to charge patients that shouldn't be charged and getting doses right. So we know the benefit of having multiple people involved in care, that it can only enhance the experience. And we have a very methodical approach because our providers never say no to patients if they want a therapy that is within reason. Okay. And back in the old days, patients would get bee sting therapy. They'd go to Mexico and get stem cells. They would go to Italy and get CCSVI therapy. And we would never discourage it and call people crazy for wanting to get somewhere with their condition, because we understood how difficult it was to only have limited options. But nowadays we have a lot better options. And we know that MS is a complex condition that not only affects the patient, but the whole family. And so when patients that have MS, they're going to feel more comfortable with people like us that know and understand MS. Now, where do you find comprehensive MS centers? You're usually going to find them in larger cities. So if you're in Florida, the three main academic comprehensive MS centers are going to be at the University of Miami, an excellent program. University of South Florida in Tampa, excellent program. And of course, the University of Florida, Gainesville and Jacksonville, excellent programs. We know them all. We feel like what we do, our mission is multiple sclerosis and demyelinating conditions. I'll also mention that there's MOG disease and neuromyelitis optica, which are variants of multiple sclerosis. These are coming more to the forefront. So you're probably going to be hearing more in lectures about these unique variants of multiple sclerosis that are now coming into really the same purview as multiple sclerosis. So the most restrictive aspects of care honestly have to do with type of insurance or lack of insurance. So we see patients that have certain insurances, and unfortunately not all specialists may participate. So when we see this level of restriction for patients, it's concerning because we do feel like it has an effect on the level of a patient's care.
Thank
So
you.
for treatment options, if you don't have an MS center or an MS specialist, see if you can find one in your state, arrange an initial visit, and see if they'll do telemedicine visits as a follow-up to where you alternate your visits every other visit. You want to watch the MS Foundation's lectures because they have some of the most unbelievable specialists, neurologists, PTs, mental health, diet, nutrition, you name it, top-notch programming. You also want to check out clinicaltrials.gov for multiple sclerosis trials you may be eligible to participate in. And understand that there's a shortage of not only neurologists, but MS specialists in general. So keep connected with the MS Foundation because they have the best, most qualified people in the field that can give you the best, most modern advice to date. And with that, we want to thank you for your time.
Thank you, everybody. That's wonderful. So that brings us to the end of our time. I'm sorry that we didn't get to everybody's questions. I'm sure Dr. Chaifetz will be back and be able to answer that another time, or you can come to one of our other Ask the MS experts where you can ask the same questions. That does bring us to the end. So if you've missed any part of this conference, it has been recorded and will be available through our MS Focus Facebook and our YouTube channels. Reply to your registration email for information on how to access those recordings or sign up for our newsletter to learn about the upcoming events. Our next teleconference is going to be actually a week from today, next Tuesday, August 13th at 4:30 p.m. Eastern. And the doctor that he was just mentioning, Dr. Ben Thrower, will be presenting Ask the MS Expert, which is really just an hour-long Q&A where you can bring all your MS questions, and he is going to do his darndest to answer every one of them. As you leave the conference today, a survey will appear on the screen. We ask that you please take a moment to give us your feedback on the program that you saw today and your suggestions for future topics. The goal is to provide you the best and the most meaningful experience and programs possible, and we can only do that if you're going to tell us what you really want to hear and what you thought of the ones you saw. So our sincere thanks to all of our attendees for your participation, and especially to Dr. Sargent, Shine, and Dr. Chaifetz. Thank you so much for all of you being here. It was really special, as it always is. Thank you so much for your time for preparing the slides, and I would say being with us, and really, truly thank you, everyone. I hope you have a great night, and we hope to see you next time.